This presentation has been assembled by Team 6 and will discuss the current state of hospice services and the Affordable Care Act. Now, contrary to popular belief, there is a difference between palliative and hospice care. Palliative care is simply comfort management for individuals at all stages of illness, whereas hospice is only for patients in their final 6 months of life. Hospice care is associated with better patient and family satisfaction, improved pain management and emotional outcomes, and lower costs. In order to qualify for Medicare's hospice benefit, patients must have less than 6 months to live, and they must also agree to give up on curative therapies such as chemotherapy and radiation therapy. Under Medicare, hospice uses a per diem reimbursement instead of a pay-per-service model, which helps lower healthcare costs while providing a more holistic style of care. In fact, the average cost saved by a hospital palliative care consult is over $2,600 per patient per admission. The Affordable Care Act requires hospice services to report on quality measures or face a 2% reduction in payments. However, these quality measures are often hard to measure quantitatively due to the nature of hospice care as an end-of-life service. Additionally, due to the relatively recent growth in hospice care, the professional skills and training required are not widely available in the United States. As part of a comprehensive health care plan, the United States needs to increase simultaneous access to hospice and curative therapies instead of one or the other, as part of a continuation of care model and home-based palliative care services. So what quality measures are hospice services being asked to report on? Well, Congress built a number of measures and programs into the Affordable Care Act designed to improve the quality of medical care and potentially reduce costs across all healthcare provider groups. The new Hospice Quality Reporting Program is one of these measures. It is the latest push from the Centers for Medicare and Medicaid Services, which pays for most hospice care in the U.S., and is therefore charged with rolling out the Hospice Quality Reporting Initiative. This initiative aims to move toward reimbursing providers for quality care and positive outcomes, while moving away from fee-for-service medicine, which allows providers to get paid no matter the quality of care, and has even been shown to lead to unnecessary treatments, needlessly increasing healthcare costs. In 2010, the Affordable Care Act mandated that all hospice programs abide by the guidelines established under the Hospice Quality Reporting Program, or HQRP. HQRP requires all hospice programs who are Medicare certified to report data related to their particular hospice facility. If guidelines are not met, providers face a 2% reduction in the annual payment update of that year. The Hospice Quality Reporting Program is currently pay-for-reporting, meaning it is the act of submitting data that determines compliance with HQRP requirements. The Hospice Quality Reporting Program aligns with the efforts to reform the U.S. health system around value. In an effort to offset the fragmented state of current measurement systems, the bar has been set high for quality measurement systems such as the HQRP. As previously highlighted, hospice has the potential to decrease Medicare costs by reducing the number of unnecessary hospital admissions, lengthy hospital stays, and emergency room visits, as well as decreasing intensive care utilization. For every dollar spent on hospice care, Medicare saves $1.52. One primary area of hospice care incorporates pain and symptom management, also known as palliative care. Palliative care optimizes quality of life by anticipating, preventing, and treating patient suffering, and is provided in a team-based format involving physicians, nurses, social workers, and many others. It is covered by Medicare and Medicaid. Recently, the number of palliative care teams has increased substantially in the hospital setting due to the significant cost savings they provide to hospitals, which averages to around $3 million a year. However, under the Affordable Care Act, the push for palliative care consultation is moving out of the hospital and into the community. Due to the new payment models that penalize hospitals for readmissions, bundled payments for certain conditions that include inpatient and outpatient costs, and efforts to reduce hospital mortality rates, there has been a rise of outpatient palliative care consultations and ambulatory consultation clinics. Also, models of care delivery are now incorporating interdisciplinary home palliative care through home health or hospice agencies outside of the Medicare hospice benefit, which are funded by capitated managed care plans instead. Hospitals are also allowing inpatient physicians to follow up with patients on an outpatient basis in an effort to keep the patients comfortable and at home. Although further work is needed to effectively establish these hospice programs in the community and train an adequate workforce, steps are being made in the right direction thanks to the changes brought by the Affordable Care Act. Here are the discussion questions we would like you to consider. Number 1. As a healthcare administrator, identify and discuss 2 additional models of palliative care that you could implement in your clinic or hospital to expand it to the outpatient setting under the Affordable Care Act. And number 2, how will further development of outpatient hospice and palliative care services impact healthcare costs and overall patient experience and outcomes under the Affordable Care Act? As a healthcare administrator, briefly explain how you would make the case for expanding these programs to your hospital's board of directors. We are looking forward to hearing your thoughts. Listed here are the references used throughout the presentation. Thank you for your attention. Have a lovely day.